Good morning. Nice crowd for this event. Mr. Fowler, you've got quite an audience, quite a following today. Kevin Fowler is originally from upstate New York. He and his wife Karen currently reside in Huntington with their daughter Katie. They also have a son, John, who lives in North Carolina. Mr. Fowler served in the United States Navy as a training department head and mission control officer. He then began his career in healthcare and served as the chief executive officer of hospitals in Texas, Louisiana, and Oklahoma. He was the CEO of Logan Regional Medical Center from 2003 to 2010. Prior to coming to Cabell Huntington, he served as CEO of East Star Health Systems from 2010 to 2013. Kevin came to Cabell Huntington Hospital as the Vice President of Clinical Services in October of 2013, was promoted to Senior Vice President and COO in January of 2014, and became President and CEO at Cabell Huntington Hospital in January of this year. It's my pleasure to welcome you.
There's been a lot going on in healthcare in our community and across the nation. And in fact, why we're in this process here in our community is because of what's going on nationally, and the challenges that we all face. You have part of the federal government that says you have to do this together. You have to figure this out, and that's the Centers for Medicare and Medicaid. And then you have another part of the government that says you can't do these things together. It's a restriction of this. It's a loss of competition. It's a variety of things. So, and those are the folks at the FTC, and they and so we're in a process of proving our point as why this is so important to our community, and we have a tremendous amount of support, including letters and decrees and different ideas or different points from a lot of different employers and agencies that we know here. So it's the right thing to do for our community, and there's many reasons why. The amount of dollars that we can save in terms of getting rid of duplicate services and getting rid of reducing those sort of if you have two services, the same services, and you're offering one here and offering one there, sometimes that doesn't make any one of them better. If you bring them together and concentrate on one service for our community and our region, and you make it stronger, you can actually be more developed, have more quality, and command the opportunities to bring more subspecialists in so we don't have to go someplace else for our health care. And that's been sort of the major theme about why this is so important. And if you look across the different things that we have, there's OB over there, there's OB over here, there's some cardiac at Cabell, there's a lot more cardiac over at St. Mary's. There's more children's services at Cabell, there's less of that than at St. Mary's. So why not put them all together and concentrate on doing a better job across the board and keeping it here and keeping patients local than to have them ship them out because we don't have some subspecialty, because we can't afford it, because we're competing at every level on everything, and we're spending money on things that if we just concentrated on, we could spend less money. And that's kind of the overall feel that we have, both St. Mary's and us, and I think at the end of the day, that's what's going to hold the day. The FTC is a little less believing in what we believe here in our community. And we're in that process of trying to prove our points with them. But we started this officially, I guess, May of 2014, and so we've been at it pretty strong since then. Just on a conference call yesterday, we have a conference call about once a week right now, or a couple times a week right now, as we're going through some more hurdles with the FTC that I think are, they want to test the water and understand it. But at the end of the day, I still don't think they have an argument as to why this is not good for our community. And so in this state and in Maryland, there's two states here in the United States that have rate regulation and certificate of need. In fact, I think we're the only two states that have rate regulation. Some have certificate of need, and some are almost as strong as what we have in West Virginia. And certificate of need means you have to prove a true need for this extra service that you want to bring. So if I want to bring another MRI into town, I have to show that there's enough need in our community to do that. So does anyone else who comes out to say I want to put an MRI or some other piece of equipment in town. We have to ask permission. We have to demonstrate our need, They have to look at it, people can challenge it, and ultimately the healthcare authority will make a decision. That's true across the board. Business owners, who tells you what price you should, in this room, does anyone tell you besides yourself what price you should set, other than someone maybe sitting out there who you're trying to compete with? Do you have any regulator that tells you this is the prices you can set? Anybody in here? In healthcare, you do. That's the only one. In hospitals specifically. They say you'll go to them and say, here's our costs, here's where we are, here's what we're trying to do, here's what we see the CPI is going to be, here's kind of where we feel we have to be, and they can say, no, I don't think so. If you follow the Gazette about a year or so ago, almost a year to date, they had an article in there about St. Francis. St. Francis had applied for about a 5%, I think 4.5% rate increase. The healthcare authority said, no, you get 1%. So no other industry does that occur in other than healthcare, and only in 2 states that occurs. And so we don't have we are not in an industry that, at least in this state, that is really it's governed so much that competition in this is kind of a funny thing. We have competition, but we have to ask permission for everything we do. There's no other business that does that. What we believe will happen, what we truly believe is they will finally see the light of what we're trying to do here. And they can see that the efficiency studies, and we had an outside company come in, and I think it's about 147 pages. I should know it because I've read it about 5 times, I think, now. But it went through kind of all the major departments and all the different things that both facilities have independently, because they can't share anything. I don't know how much St. Mary's does in certain areas. I don't know what they charge for this. I don't know how many staff. I may know staff, and that's about all I know. I don't know salaries. I don't know cost. All that is separated because during this process we have to do business as competitors until someone says we can actually come together and make this deal happen. But I can tell you that the amount of savings goes into tens of millions of dollars over the first 3 years, and then steadies out to almost about 35 million, 36 million is what the expected savings are to the healthcare process in the Huntington market consistently year over year after those first 3 years. That's a huge amount of money. Can you imagine taking some of that and concentrating on the next level of care? Can you imagine having all the subspecialists that we need for our kids, that we need for our parents, that we need for us here in town? I can tell you the outside world in healthcare, and when I say outside world, folks who are an hour and a half, 2 hours away are looking to us to see what's going to happen in healthcare because they want to align with Huntington. They see Huntington has become a center for healthcare, a destination for healthcare. And why that's happened is because of the strength of the School of Medicine. Without a doubt, they've done an outstanding job. Our relationship with us has created, with them, our relationship with them, and they have a relationship with St. Mary's, has created the opportunity for subspecialty to come here, has created the opportunity for education so we can keep local kids here getting that medical education and the residency training and keep them in our community so we can continue to grow. People are coming to Huntington. The mayor and I had a conversation probably about 3 months or so ago, and he was just completely amazed as to what's happening in this town. And we're going to get industry back. I hear this, and I believe in it. We have healthcare, and it's coming even stronger. I will tell you that in 5 years' time, we'll probably have 50 to 100 more doctors here. And not because our population right here is going to grow necessarily that much. More and more people are going to depend on us for that specialty care. They're looking not to go to Cincinnati, not to go to Cleveland, not to go to Columbus or Lexington or Louisville or East. They're not looking. They're looking to come to us here in Huntington. And we, in this community, have created those opportunities where you have such an open door and welcoming demeanor in this community. It reminds me so much of Logan. Logan's very similar in terms of the personality. Please come in. Please become part of our community. Please make a difference. We're here to support you. And I think the physicians feel that. Our recruitment, you have recruitment that goes on. A doctor goes, makes a decision to go someplace else, so you have to replace that. But we're doing less and less of that, and we're just doing more growth now. When I first got here a couple years ago, we had several folks leave. Now people are staying, and we're staying because they see what's happening in healthcare, and they want to be part of it as well. And so for me, the opportunity to come to an organization and to a city like this has been a dream of a lifetime. It's the place where you can say, I'm not here bringing something out of bankruptcy. I'm not here bringing two, like in Muskogee, Oklahoma, where we brought two hospitals that were at war. It wasn't the relationship that the two hospitals here have about who spend more time concentrating on the care of patients and less time on really fighting each other. Over there, it was outright war. And we were able to bring those two hospitals together into one system over there. So for us, to come to this community and to find such a quality organization in both hospitals, and to be part of the opportunity of making a true difference in healthcare for our entire region, without a doubt, it's the most outstanding part of my career to come to a community like this. So we aren't planning on going anywhere, I can tell you that. So you're going to have a hard time getting rid of us. So Hunt Kate, my daughter's in the audience right there. So are there questions or any thought processes? Anyone? Yes, sir.
You've used the term subspecialty 2 or 3 times.
Mm-hmm.
I'm not sure I understand that. Could you define it and maybe give us an example or two?
Absolutely. Absolutely. I even call some of them uber subspecialties, but the subspecialty is, let's say you have a pediatrician, and you also need a neonate. In our world, we have a neonatologists who are pediatricians who are specialized in neonates, so in the very small babies. So when we have, unfortunately, as we do in this community, we have many babies that are born much earlier than they need to be. I've seen them as young as 23 weeks and stay 6 months or 5 months to come to full term in our hospital and then go home. We need those specialists to be able to manage those patients and move them from where they are to a full life. You have neurosurgeons that specialize in DBS, which is deep brain stimulation, Parkinson's disease, a tremor, and stuff like that. We have those specialists here. That's the subspecialty area. So you have neurosurgery in general, and then you have subspecialties that concentrate on 1 or 2 specific areas. We have intensivists, which are not just an internal medicine doctor, but they're a doctor who specializes in the care of patients that are in an ICU setting. So those are the kinds of subspecialists I'm talking about. There's even more of those out there in the big centers who are very specialized. Surgical oncologists. We have surgical oncologists here. We have gynec surgeons specializing in that. Dr. Oakley is one of those. People come from a long, long ways to see these doctors because they can't get that care anywhere near their area. And so we have a unique opportunity here to grow that. That's a great question. Other questions?
What would happen to our costs if they took the wraps off of the control costs?
Well, that's...
We really have a choice. I mean, we go to McDonald's, we see the board, and we can order what we want. I can't find anywhere where you all list appendectomy.
Absolutely, absolutely, and that's been you're exactly right. Number one, costs are again regulated specifically by the state. I can't go in there and with this deal done, I can't go. Okay, this is what we're going to do. We're going to do a 20% increase in everything, and everyone's going to just have to suck it up. Can't do it. It's against the law. If we go over the rate that we're given right now, we're penalized by the state. If they see that our rate calculation or that what we collected is greater than what they expect us to do, and that we did something greater than what we put in our application, what's called a rate application, then they will come back and penalize us and take the money away. Williamson Memorial took a big beating because they tried to overcharge, and so you already have something that's a safeguard. The issue with the FTC is a bit about having control over the payers. The insurance, Blue Cross and Blue Shield. That's not true either. We can't go in there because all that stuff is, first of all, it's public knowledge. All the contracts I have with Blue Cross and Blue Shield or anybody else, the state has access to those, and so the state has them and knows what they are and can publish those. we can't go in there and muscle the payer at all, which is what the thought is, oh, they're going to just do whatever they want. We can't. By law in this state, and that's not true in Ohio, the other way. Ohio, in Ohio have no rate regulation, no problem like that. All of a sudden, they've had this plethora. Someone actually did a 20% increase in their charges to everyone. We can't do that in the state. So even if I wanted to, I can't do it. I don't want to because everyone in here, this is so important to us to keep costs down. You're going to all throw me out of here if I do it wrong. I mean, we got to do it right.
What would happen if we took off the state's regulation?
Well, that's where we are right now. If you remember, the AG, the Attorney General, put out advertised, if you saw that, mentioned or made an announcement back a month or so ago now. And that announcement basically said he's come to an agreement with us to recognize and hold us accountable on a variety of different things. We can't change rates. We can't do these things. We have to keep within certain limits, and he's monitoring that for up to 7 years, I think it is, right? Yeah, 7 years. So we can't just go out there and make changes like that.
But if we did take the wraps off, what would you all do?
Well, again, it makes no sense to do that. What I want to concentrate on is building. I don't need the price to go up. I need more services to come to us. I need more people to come to us. I need population management, be able to work with primary care physicians in outlying areas, work with hospitals in outlying areas. I don't need the price to go up. I just need more of the same thing I'm getting right now. So from a business perspective, do you put $100 on one thing and get 2 of them done, or do you put $10 on 500 things and get those back here? So it's about keeping the volume, keeping the number of folks here, using our facility. Now, healthcare has changed. Population management's driving everything to the outpatient environment. But our hospitals are full. It's been doing this for a while. Why is Huntington hospitals full? Why are they full? Any sense? Because they don't want to go someplace else. They want to go to us. And and they know we're having this subspecialty. They want to stay in our area, and we have more and more relationships with people further away than we did before. We want those folks to come to us, and our hospitals will stay full because those subspecialties and the expertise we have in them, and those things called centers of excellence, where we have the best demonstrated practices for the clinical stuff we do, as those continue to grow. People are going to come to us, and that's the goal. So I don't need to make price increases and make these huge price increases. Do I have to respond to the cost of doing business? I do. If the cost of everything goes up, what do I have to do? I have to try to keep up with that so I can at least continue to grow and be financially viable for our community. Great. Those are great questions. Other questions? Ed?
Different thing, but a lot of people have brought up talking about St. Mary's and Cabell and the whole employee situation with, some in the union, some not, and that may exist already, within Cabell. How would that?
Well, I'm not here to. I'm certainly not here, or if this transaction actually is completed, I'm not here to force anything on a set of employees that they don't want. So if the union is, to me, I'm not going to automatically say, here employees, you have to do this thing. First of all, I don't think I can legally, but secondly, I'm not going to do that anyway. They have to decide on their own, and that's still, it's going to be sometime way after a transaction, and I can't tell you right now when that transaction actually will be completed. But good question.
So what is your biggest challenge from a management standpoint now that you have in this transition? What's your biggest challenge?
The biggest challenge, is we want to jump forward but can't. We want to jump forward in terms of looking how we know we can consolidate and bring things together and start focusing each service line towards this next level to this. Let me answer that. Let me give you a little something ahead of that first. In healthcare, what we are studying and learning and watching has been happening over the last several years, and what will continue to grow, is the competition that's not really devoted to quality patient care. that they're devoted to bringing you into a pharmacy, bringing you into a Walmart or Target to get you in the door, and to treat that moment of time that you say, I think I have a cold, I think I have this, I think I have that. Is that efficient for you? Yes, it is. I got to go do this, I got to do that. It's great. They're out there and they're taking on patients like that. But that's the only follow-up. It's not that you're going to get a follow-up appointment because you have 5 things wrong that you need to get fixed, unless they link in with somebody else. So, what does the patient, when we hear this is happening, what does the consumer want? So the guess is, we can sit, or I should say, we can sit here and guess what the consumer wants, or we can sort of ask people. Well, the consumer wants convenience. The consumer wants transparency, price transparency, and we are working on that now. The consumer wants quality care, and the consumer wants to be connected to their healthcare provider. Connected in a way that's not just, I know your blood type, and I know your blood pressure, and I know if you're diabetic and stuff, but to get to know you as an individual and treat you as that in every instance that you have. Those are probably the 3 areas that we have to concentrate on. How do we make it more quality? We have to have more centers of excellence. We have to have the best in oncology care, the best in general surgery, the best in bariatrics. We had a bariatric survey yesterday and got an outstanding result on that, and we'll publish that once it's official. But we have to be the best. That's got to be a given here. Then we have to have the access for patients so they can get to us for the things that they need. We don't need them to come into the ER if they really need to be in an outpatient setting. So we have to be better at coordinating how that happens. So for those clinics that are out there that are sort of standalone, that are popping up across the United States, not too many in this state, but there are a few, we have to be connected with them. So the patient, although you get the access and the flexibility of getting in to get to something like that, we have to figure out a way to be connected. So the long-term continuum of care that we have for you as a patient is being taken care of, that we're making sure we're catching things early and delivering care in the appropriate setting. So to answer your question, what's the hardest management things to do is, from a strategic perspective, it makes no difference if it's one hospital or two different hospitals trying to still do the same thing, or if it's one entity. The strategic plan has to be designed around those items. So, I'm not giving you a secret that St. Mary's doesn't know. They know the same thing, and that means bringing in those subspecialists and bringing in more of the kinds of doctors in settings that we need, and getting them in line such that a patient shows up in an outpatient setting, maybe over here, we can transfer that registration over there to a automatic registration over here, so they can walk right in and go right into get their X-ray, get their lab, all the way through the process. We're not there yet. There's very few hospitals are. Even those who have the same healthcare IT systems in their practices as they do in the hospital. KDMC is an example. They have Epic. It's in their practices and it's in their hospital. They still have a connectivity problem between getting that patient from that outpatient setting to the hospital without a lot of confusion and a lot of wasted time on the part of the patient. So we're going to have to concentrate on those things. And from a management perspective, I got to keep people focused doing that. That's a good question. Thank you. Yes, sir.
Kevin, you alluded to the agreement with the West Virginia Attorney General, the 7-year deal.
Mm-hmm.
What does that actually mean, and has it changed your plans in any way?
Well, that one's a sort of a contingent. If the deal goes through, we put it all in place. But it's kind of funny because some of those things are already in place. We've already executed on some of those items. From an operations perspective, really doesn't mean much. We knew we were going to commit to things that will require us to keep our costs down, that will require us to be efficient and deliver and a higher quality care. So it falls right in line with exactly what we believe we have to do in our community, either as an individual hospital or, again, as a system. We think we could do it significantly better as a system, so does the AG. That's a good question, thank you.
Kevin.
Yes, Linda?
We appreciate you so much as a partner with the School of Medicine, and you're great. Devil's advocate, and because I believe the merger's going through, that one little brief moment that you think it wouldn't, what is your strategic plan for Cabell Huntington Hospital if that does not happen?
Well, that one I'm not going to tell you. I can get away with 1 or 2 murders maybe, but I don't think I can kill everybody in the room. So, I will beg away from that one right now. We definitely have some significant plans ready to go. That ultimately, if you kind of step back far enough and look at what's going on in healthcare in general and listen to what I've said so far, it's almost the same plan with or without the transaction. And I think we're going to be very, very successful at it. And it's because of the relationship that we have with the School of Medicine, I think, creates more and more opportunity. Yes?
I was just going to say, a lot of people are worried about how much the charge is. It really doesn't matter how much the charge is. I have a mastectomy boutique, and it's whatever the insurance contract says they're going to pay.
That's right.
Is all you're going to get paid.
Yeah.
It doesn't even matter because the hospital has to write it off. I have to write it off.
That's exactly right.
So you're under control with
Yeah.
the insurance plan.
There's lots of different payment things called APCs and DRGs and all this stuff. Basically, you do a contract with Blue Cross and Blue Shield. My charge I can tell you for Medicare, Medicaid, I may be charging $2,000, and for Medicare, I might be getting $500. So the charge really doesn't impact a lot of things. And for Blue Cross and Blue Shield, where you say, well, okay, if it's a percentage charge contract or something like this, most of those are disappeared. They're saying this is a DRG. This is a diagnosis-related group, and for that diagnosis-related group, we're going to pay X amount. Do you agree or don't agree? We're going to do a contract with you or we're not. So my charge could again be $2,000, and maybe I get $700 from Blue Cross and Blue Shield. So what I have to do is not go into a contract that I'm ultimately losing money on because, but again, they know what we make in the state. Everything's open to every insurer. They know exactly how much money we make. In fact, you guys see financial. We print out, or by law have to send out financial statements, and they go to the state every. I'm sure, if not every month, certainly by quarter and certainly by year. And we have cost reports to do, and those cost reports are public. Anyone can dig into them. I don't think anyone would ever want to unless you had a specific reason because they're pretty darn thick. But at the end of the day, it's truly, what am I going to get paid, and is that going to be enough to cover the true cost of doing that for the staff, for the equipment and the technology, for the physician to be able to bill for his services? Will I be able to cover those costs? Good point. Yes?
Because we have 2 hospitals here, and when this transition occurs.
I like when. I like that word. When, not if. Okay, we're past, that's right. There's no if in this. When, that's all right.
That the School of Medicine, will it trickle over and physicians will have privileges in both hospitals? Because a lot of people will go to one hospital because they
Absolutely.
because
Absolutely.
privileges.
Yeah, without a doubt, both part of this is both hospitals will require, it'll be basically open medical staff. So any physician can practice anywhere they want to. Some may say, I don't want to practice over there at all. I just want to practice over here because that's convenient for them. We don't see that as a problem at all. It's been doing it kind of that way all along. I don't see that changing.
I like the idea that you said it's not going to be a problem.
Well, at the end of the day, will everyone be all excited about, from a physician's perspective, will everyone be all excited about what happens? Because of the uncertainty, no one knows. Everyone's running around pretty spooked. I get phone calls all the time from physicians over at St. Mary's asking, what's this going to be like? And, I give them pretty much what I'm telling everybody here. We don't know. We know what the requirements are in order to meet the needs of the AG and the FTC and what we've said we will do. We know that, and we know that every doctor here, unless they're sitting around not doing anything, is needed. And we know there's shortages nationwide with physicians. We are fortunate that we don't have that here. So the School of Medicine is important to be strong and grow, continue to grow, and add more residencies. I think over the last couple of years now, we've had, since I've been here now, three or four different residencies with more coming. So, you know, we have nephrology coming, or now here. We have neurology starting up. We've got general dentistry. Psychiatry just started up. There's a lot coming. And so we need to support that in terms of the strategy is, if I'm going to tell you any strategy, your point about having them at both facilities makes 100% sense, and from a strategic perspective, it's the only way to go. Other questions? Man. Oh, no, you don't get two. You know, you only get one. I thought Katie was going to ask me one. I wasn't sure there, so.
It's been a little while now since the Healthcare Reform Act, and I've been to different presentations, and some just become politically charged, and you know. But I'm curious, you know, from your perspective, what's right about it? What's wrong with it? You know, if you were king, how would it have been done, maybe, or you know,
I'm just
reflecting, because you've been in the business a long time, and thinking about what it looked like.
Well, Lisa Chamberlain's in the audience, and I told her, if I go down on something, make sure you drag me out before they can stand up and run me over. And this may be one of those. No, regardless of what we think about Obamacare, it created a change in healthcare. The Affordable Care Act has driven everyone to look at healthcare differently than they've done in the past. I don't think it's going away no matter who sits there anymore, because it's on a roll that's not going to stop. We're going to get paid for performance. So if we're not performing well from the patient's perspective or from some clinical measure, we're not going to get paid for that service, or we're going to get penalized for it. Right now, we're already in those kinds of environments. We have where Medicare automatically, at the beginning of the year, says, I'm taking 2%. I'm going to hold on 2%, and you don't get 2% back if you don't do these certain things at this certain level. And so 2% of when I say 2%, it's 2% of like net revenue from Medicare. That is a huge amount of money for our hospital. Not getting that back would not be good. So what we're seeing is that was stage one. Stage two is now we are going to be charged, and actually have signed up as a trial, we're going to be charged with the responsibility of what's called shared risk. We're going to do a shared risk program, and already signed up for it, and we're in that trial process now, for a DRG called simple pneumonia. Well, when I said DRG, remember it was diagnosis-related group. Well, DRG, with simple pneumonia, means there's also complex pneumonias, and there's all these things in here that people are really, 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 really sick. Well, Medicare divides costs between the acute care setting and the post-acute care setting. So for the acute care setting, that means a hospital. You are in the hospital, you're there for a length of stay, we've done X amount of things to take care of you, and now our job is to get you out, make sure you're healthy enough to go out and not come back within 30 days, because then there's another penalty. If they come back in 30 days, we get penalized and don't get paid for that second readmission, even though it could be a car accident, had nothing to do with the original diagnosis. So now we are going to be responsible for not only the care that in the acute setting where we have complete control, but we're responsible for the next 90 days of that person's care, no matter where it is. So if we don't do the right things and the person ends up at a skilled nursing home and stays there much longer and doesn't get the care, and their length of stay is longer and longer and longer, whatever it might be, we are responsible for that care. So now we have to build quality relationships with good good clinical settings outside of the hospital, such that we can control the cost of that patient, because we're going to get penalized for it. So you could say, well, why would you ever sign up for that? You sign up now or sign up later, but somebody's going to sign up. You're going to have to try this out and do it. And right now, we've done it for one specific DRG. So far, we're still too early in it to tell you exactly what's going on. I think we'll do okay. We're going to have to figure out ways to work with them and make sure that their quality is such that we don't get penalized. Why would the federal government ever do that? They don't want to manage it. They want us to manage it. They're putting it back on us to do, and that's okay. You know, bring it on. We're going to do it, and we'll be successful. It's happening right now nationwide. They're doing one on total knees. Some hospitals are much further ahead than we are, and we're much further ahead than many hospitals in this state and in around us. No one else is. I don't think CMC is even doing one yet. We're going to continue to do these things because ultimately we'll have no choice. We'll have to take care of the patient, make sure we do a great job here, and then we're going to have relationships with those quality facilities outside that will take care of the patient the way we expect that patient to be taken care of. So it's going to be a challenge. And that's exactly why those kinds of risk things that we have to take, that's exactly why this transaction means so much for our community. Other questions? Yes, ma'am.
Good morning. Kevin.
Good morning.
How are you?
Good to see you.
How about not a question, but a compliment? Okay.
I'll take those.
All right. At the food bank, we certainly appreciate the support of Cabell, but certainly the willingness to partner with us in relation to the Affordable Care Act, where the provisions of the medically tailored food boxes and meals. Your staff have been very open to us and trying to figure out how we can bring that to our area, which will provide increased nutrition, better chronic illness management. So thank you for that. It kind of helps us to be a better partner in the community and a better partner with you.
Thanks so much. I appreciate that. You know, one of the things that I think Cabell has always been great with, and I think St. Mary's as well, but certainly from personal experience, the amount of involvement in the community that Cabell Huntington Hospital has had over the years, and certainly over these last few years that I've been here to witness it, has just been unbelievable. I'm in awe of the time and energy that our staff and across the board, nurses, volunteers, everybody, that are out there doing these things. It just is. You just to walk into an organization that has that or gets it like that is phenomenal. Just I don't know how to describe it. I just am so proud to be part of it. And occasionally I try to help. Even personally, I like to cook. So for those, we did a little cooking, didn't we? So but it is. I think it's a charter. It's something we have to do. Become part of it. Make sure we stay connected to the community because I think that's going to make the differences down the road. Thank you for that. Any other questions? Thank you so much, everyone. I really appreciate it.